So I just got a message from Shedza that we can start. So hi everyone, my name is Jana Slonkova and I am the neurologist of Clinic of Neurology in Faculty Hospital in Ostrava. My specialty is mainly epilepsy, sleep disorders, and during the shifts, the night shifts, I can do practically acute neurology as well. So my task today is to tell you a little bit about sleep disorders in our daily practice, why it is important to know about the sleep problems of the patients. So what is it, sleep? Sleep is a rest state within minimal physical activity with reduced perception of the environment, with significantly reduced mental activity. EEG, when we provide, is different from visual recording. Related to alternating light and dark circadian rhythm, the sleep is related to it, we have quite a lot of energy conservation during our sleep. We have tissue restoration, our tissue restorates, and of course the nesting processes are facilitated. We should know that sleep has some organized status. We divide two main sleep stages. We have non-REM and REM. In adulthood, I would like to point that I am a neurologist for adults, so I will be talking mainly about adulthood troubles. We make a record of the patient's sleep, and in this record, we can recognize cycles. You see at the bottom of the picture, this is cycle 1, cycle 2, 3, 4, or either 5, and each cycle consists of non-REM and REM stages. You can see that this patient is going to sleep at about 11 p.m., wake up at about 6:30, and you see that the cycle has some length. In a percentage, we see that non-REM sleep we have in 3 stages. Is this non-REM 1, 2, and delta, let's say non-REM 3. And these stages, you can see that the second level, second deepness, is about 50%, and the other is about 20%. Delta sleep is very important for the nesting processes. Wakefulness is when we should sleep, we shouldn't be waking up. So it's not more normally than 1% of whole sleep. Very important for the human brain is REM sleep, and it consists of maybe or around 25% of the length of the sleep. Now here, I would like to point to all students, when you study and you see that the brain needs hours and hours and hours, let's say 8 hours, 9 hours, or 7 hours, the brain needs that length of the sleep for its sleep, because it cannot know that whether you go to sleep at midnight and wake up at 5 a.m., then you see the stages, the cycles cannot pass through as it's normal they should go. So I would like to ask you, and very much ask you, just leave your brain to sleep, and it will work for you properly when you study. Because if you don't sleep and you study hard, you cannot remember all what would you like to remember. We see that the sleep is regulated by the brain, of course, itself, and it needs and uses several structures. One of the main important ones is nucleus suprachiasmaticus and glandula pinealis, because these two are involved in producing hormones. Nucleus suprachiasmaticus works with the light and glandula pinealis with melatonin. You see that in a human brain, within the age, the level of melatonin changes and is the most effective when we are about 10 years old, and it's lowering and lowering, and when we are over 70, it's quite low. But you see that it starts to grow at about 10 p.m. and again it goes down in the morning. So it is night hormone. So also here you can see if you want to study during the nights very hard, so this melatonin activity could be altered and you are not in that good condition in the morning anymore. Melatonin plasma levels also decline rapidly with the age, and you see it's a similar picture that the most of it you have when you are young, and then it lowers when you are older. What is also very much important to know that brain is a leading structure for our breathing, especially brainstem, medulla oblongata. We have 4 breathing centers which cooperate and work together. Sleep disorders are, of course, divided somehow, and the last classification, international one, made by American Academy of Sleep, was released in 2014 and divides sleep disorders into 7 main groups. We shall now go step by each. If we want to diagnose sleep disorders, we need some mechanism how to do it properly in each patient. We need, of course, its medical history. Then we have questionnaires, and especially I have pointed here Epworth Sleepiness Scale, which is self-reported questionnaire when the patient evaluates himself or herself in such conditions like sitting and reading, watching TV, sitting inactive in public place, be a passenger in a car or a car driver, or sitting quietly after a lunch without alcohol. And the level of the points are 0 to 3, so maximum points is 24. If somebody evaluates himself or herself to 24 points, it means they are constantly sleepy. But if it's 0, if they say they don't feel any sleepiness and they are okay. So the cutoff value for excessive daytime sleepiness, we say it's 10 points and above. What else we can do, like objective methods? We have cardiorespiratory polygraphy, we have polysomnography, we can use multiple sleep latention tests. We can ask our colleagues of ear, throat, nose specialization, pulmonary, neurological, psychiatric, dental surgery. So we are more specialties who are involved in sleep medicine and we cooperate together. Of course, we should know if the patient complains about some fatigue, sleepiness, brain or sleep troubles. We should know the brain is otherwise fine and without any structural lesion or progressive lesions and so. So MRI scanning is also very much appreciated. One of the possibility how to diagnose severe sleep disorder, as we say narcolepsy, we shall be talking about it a little bit later. We can also provide lumbar puncture to examine hypocretin orexin to evaluate its level, and if it supports this severe sleep disorder diagnosis, then we shall see later how it looks like. Of course, we can also exclude any chronic inflammation, so other etiology of sleepiness, abnormal sleepiness. This is polysomnographic recording. You can see the child because this picture is from my colleague from Children's Neurology here from the clinic. And you can see there are quite a lot of virus around the face, but we need it because we need to know everything about the EEG. We need to know electrooculography, we need to know EMG, we record musculi mentales and musculi tibiales on the legs, upper, lower extremities. Also, we need to know everything about breathing parameters, so you see these sensors in his nose. Also, we need or we can record ECG, and if it is in need and it is indicated, then you can also use esophageal pH measure. We don't usually do it in adult sleep medicine ward here. So the first group of illnesses is about insomnia, when it is more common in elderly, female, depressive, people who are depressive. And the causes are what? The patient is usually in the stress or is under some medication or has other disease like asthma, bronchial, or chronic obstructive breathing pulmonary disease. You can have the patient can have a periodic like movement disorder or can have sleep apnea syndrome. Of course, the insomnia also can be triggered by secondary from surroundings like noise, like some barking dogs or some people making noise around, of course. Insomnia, it has the contributing factors about that are that the patient chronically has a trouble of falling asleep, and during the day they start to feel what happens when I should go to sleep again, or if I cannot sleep again, what I will do. And the people usually also break the rules of sleep hygiene. We usually speak about insomnia. It could be acute or chronic, and it is about 3 times per week that the people cannot fall into sleep, or it should be also some longer period than we speak about the chronic problem. Of course, for our task is to know why the patient exactly should be complaining about insomnia and what happens if we do not try to help him. You see the arrows, either they go both-sided or just one direction. So you can say that somatic illness can cause insomnia, but vice versa as well. Insomnia will produce low quality of life of the patient, high absence at work, high risk of accidents, cost of care grows, cognitive impairment, and psychiatric disorders can be the both sides direction, of course, seen. What can we recommend to patients as neurologists? Because I would like to point that primary insomnia is more likely a question for our colleagues from psychiatry clinic. But as a general doctors, no matter what specialty you will be, or you are, it is about elimination of treatment and treatment of the cause. It means if the patient doesn't sleep because he has great pain, we are supposed to lower the pain. We are supposed to eliminate noise. We are supposed to point possible disturbance factors and exchange regime. But what can we do with a patient who complains about the sleep trouble if they go to night shifts, if they are people who work long hours during the nights? It's very difficult because they do not want to lose the job, but they complain about the health troubles. Also, what we can say to someone who says, I live nearby the restaurant and during the nights it's noise and I cannot sleep. So the first factor you can say, oh yes, you can move, you can just go to live somewhere else, but it is difficult because nowadays it's impossible, or for some people it's possible to change it because it's quite a lot of money to spend on it. So you see that even the patient complain, not always we can do basically the best what they want to do, what from us to hear, let's say. Of course, the patient should be hardly following sleep hygiene system of sleep hygiene recommendations, like to go regularly to sleep, not to drink too much alcohol before they go to sleep. They shouldn't exercise in long evening hours because the body would be too excited, and so they should just modify their lifestyle. If the insomnia is short term, is transient, then it could be maybe just spontaneously resolved. But if it goes to the chronic state, then we should use therapy, maybe also the medication. If it's only short term, you can help with the third generation of hypnotics like zolpidem. If it's chronic insomnia, we sometimes, as neurologists, administer antidepressants, but we also ask our colleagues from psychiatric clinics to help. Effective can be cognitive behavioral psychotherapy, but it is quite low access in our region, so accessible in our region. So it is maybe just a theory how to help the patient, but our colleagues from psychologists should strengthen the patients to have them in their offices and in their care using this method, because they say it is effective. Second main group of the sleep disorders is sleep-related breathing disorders. This I would like to point maybe more precise, because it really interferes with many patients, and you will see why. It is quite common disorder, and it has negative effects on physical health, daytime functioning, mood, cognition, and others. What is it? Sleep apnea, especially obstructive sleep apnea. Sleep apnea is a repetitive, complete, and/or partial cessation of breathing due to collapse of the upper airways. If we speak about complete cessation, it is apnea, and if it's partial, then it's hypopnea. It is also quite logically accompanied by oxyhemoglobin desaturation, and it all results in fragmented sleep and changes in sleep architecture. It is about reduction of sleep stage 1, 3, and REM sleep. Non-REM 2 stage sleep is commonly longer than normal. Apnea, when it's pathological, it is the breathing interruption for 10 or more seconds. We consider as physiological, as normal, up to 4 apneas or less per 1 hour of sleep. The number of apneas per 1 hour of sleep is called apnea-hypopnea index, AHI. Oxygen saturation drop index we also have to measure, and we call it desaturation index, ODI. And also you will see the result of the record, of the polygraphic record, T90 in percent. It means how many percent of time of sleep the patient spends below 90% level of saturation in peripheral blood. We know that 90% is the level of cutoff level of normal. What is above is normal, what is lower, it's pathology. And of course, it is also very important, the drop, which is in ODI index. The patient can have the saturation above 90, like 98, dropping to 90. So you will have T90 0%, but when the desaturation is about more than 4% from the average level, then the pathology is obvious. We distinguish, or we have 3 types of apneas. It's obstructive, it's central, and it's mixed. Here I would like to say, or I would like to show you how it looks in polygraphy, the record. This is flow, so you see the patient breathes, and then is breathing, and then it's apnea, and you will see that it is, or you can see it is 20 to 22 seconds, the length of it. This window is 5 minutes. Then you have 25 seconds, 26 seconds, and so. Here is the effort of thorax and effort of abdomen. And you see that the movement is still present. So it means that the collapse is truly in the throat of the patient. And here, these peaks are snoring. So you see when he breathes or she breathes, it doesn't matter whether it's a man or woman. Here he breathes, or she, and here's snoring. And here you can see the SpO2 in percent. So this is the ODI information. And you see that here the lower part is 85%, 85, 85. And the peak is of course above the level of 90, which is this one. So you see some sort of sinus shape of this line. Here we have heart rate, because from the sensor for desaturation you can also measure the heart rate of the patient, and you also see that it's not very stable. And very important information is also to know that this patient has this episode when on the back, which is obviously logical because it is about also the gravitation. This is another shape, this is another type, this is mixed apnea, and you see it is 45 seconds long. It starts as a central type, which means there is no effort on thorax, no effort of abdomen, and no flow. But in the middle, it switches into the obstructive type. We count these as obstructive. And also you see the similar shape of desaturations, and this position is on the right side. I would like to show you a little bit how looks the patient with central sleep apnea. This is polysomnography, pardon, excuse me, sorry, polysomnography. And you see here that this is no flow, no effort of the chest, and no effort of the abdomen. So these apneas are central. You also see here the hypnogram, and you see totally different shape from the previous. I said the normal type is about the cycles. So you see many arousals and waking ups. Hypopnea is measured when the reduction in breath volumes is at least 50% or less of the normal amount or normal volume, and it is also accompanied by decrease in saturation of the oxygen of 3 or 4%, depends how the device is settled. You also count these hypopneas into apnea-hypopnea index, so they go together. The treatment in Czech Republic with special devices is given to the patient when reaches the AHI index 15 or more, and this prevalence in general adult population is ranged from 6 to 17%, but with age it is rising up, and you can reach up to almost 50%. The OSA prevalence is also greater in obese and men and women, but men are more likely ill than the women in about the range of 4 to 1. Who is the typical OSA patient? You can see this one is a guy called Jack. Is the one you could know from the book by Charles Dickens, The Chronicle of Pickwick and Club. And we call it, that's why we call it Pickwickian syndrome. It's a typical OSA patient, is a man with hypertension, obesity, he has been snoring for long years, his family is positive, has family history of snorers, and sleep breathing disorders could be like, they can say, I have several times during the night sort of dyspnea. Also, they can consume alcohol, smoking cigarettes. Their health-related behaviors are linked to OSA. They can have lower activities. They just say, I'm not interested in anything. I just want to sit down and a little bit sleep. They have depressed mood and impaired cognitive functioning. They are sleepy during the day, and of course it could have the serious sequelae in the most bad possible way. You can imagine somebody who drives a car and gets sleepy behind the wheel and makes some accident. First degree relatives of OSA or SAS, we say patients have twofold higher risk of sleep-related respiratory disorders. If the snoring is present, so 3 times more, you are in risk to have also sleep apnea. Of course, you can have hereditary etiological component of obesity, but most of us, I would say, we like to eat. Also, you can have hereditary malformations of the craniofacial skeleton and its abnormalities, of course, and you can also have OSA in chromosomal and gene defects like Down syndrome and so, or lip and cleft palates. It has quite a lot of consequences with cardiovascular system, and that is why I like to talk about it that much, because cardiovascular system, brain strokes and myocardial infection, they go hand in hand together. And if you have sleep apnea, you usually have increased systolic blood pressure. And also, you are not deeper during the night. It means that if you are in a cardiovascular care and you go to your specialist and you will have Holter monitoring, which means 24 hours or longer evaluation of your blood pressure, then they can find that during the night, normally we have lower systemic blood pressure. And these people with OSA, they don't do it. They say they are non-deepers. But if you if you have no deeper blood pressure during the night, then it means that during the day it will grow up. So it is the first risk factor for having high blood pressure during the day if you have sleep apnea. Then also left chamber fulfillment and myocardial relaxation disorders do matter us, because it also can trigger contractility disorders, and of course the OSA can play quite a great role in heart failure patients. It can worsen. It is worsening factor for ischemic myocardial disease. It is also increased risk for malignant arrhythmias, because if we remember the picture, how the patient breathes and how the patient is affected by lowering oxygen, it means also that heart doesn't work regularly, and malignant arrhythmias are more likely triggered easier. And when you have the stroke during the night, it's also quite high risk to have sleep apnea, because it somehow again is connected with the heart and the cardioembolic etiology. Neuropsychiatric consequences. I just said previously that we need to work together with psychiatrists about the insomnia patients. But also, if somebody has night sleep fragmentation with more frequent awakenings reactions leading to excessive daytime sleepiness, the patient itself or himself or herself, they refer to specialists. I am maybe depressive because it's now I have no any more fun from the life because I want to sleep all the time. So sometimes they already get the antidepressant medication, but it's not the point, because the point is sleep apnea. Also, they can complain about decreased reactivity, memory impairment, impaired frontal functions, impaired manual dexterity. They say I'm not my results of what I do is they are not so well. What is it? Impaired frontal functions, like it is about the mood, it is about how they behave, and also the patients could be meant as demented, which is not very true. And also they can have personality changes. Maybe I should point, because I probably didn't say that clearly, that at the end of the long apneas, obstructive ones, the brain has to wake a little bit, so that the muscle tone of the throat muscles is normalized, it's not so low, it's better. And then the upper airways, they open and the patient can breathe a little bit again, but they again fall into sleep but they do not know they do it. So it is hardly to be getting this information from the patient, from the patients. You need someone else usually, and they speak about their beloved or their friends or whoever, just seeing the type of breathing of the patients, and they tell them, and then they start to think of it more clearly, and then they ask for help. Night symptoms. It is about respiratory arrest in sleep, about snoring, dyspneic episode, dry mouth, arousals or waking up, sleep fragmentation. They are agitated, non-refreshing sleep. They have nocturnal polyuria, which is very annoying, and they think they should go to neurology care, but it's not so at the point because the etiology is somewhere else. Also, they can be very much sweat. Also, they can have difficulty falling into sleep again, and they have night terrors or waking up confusing. Daytime symptoms. They will probably tell you, I am sleepy, I am very much tired, or I cannot remember things I want to. I have sexual dysfunctions. I have morning headache. And also I can have feeling in my esophagus like I have epirosis and so. This is cardiorespiratory polygraphy. It's the device I show you the little graphs. So this is very tiny thing, tiny box with the measuring the oxygen and some little wires to measure the movement of the chest and the abdomen. So it's very easy, it's portable, they can take it home, so it's very comfortable for the patient that they don't have to be in the hospital. Here, normal breathing you see, and here I already told you or shown you the episodes of obstructive sleep apnea. This is polysomnography, you saw it, and this is the patient when I would like to try to show you, and I hope you hear it. Where is it? Here. So you see the patient is not breathing, there is no airflow, then he breathes a lot, moves a bit, and it's go again and again and again and again, and he does this only when is he on the back. When is he on the right or left side, it is not there. So the help for this patient could be, as a first recommendation, please do not sleep on your back. And how would you do it? Probably would put some annoying thing, some subject on this back to the pyjama, and then you might be successful, but of course you are supposed to check it. So conservative treatment. Here I would say is my quite of favorite pictures. You sit by the table, you have something very perfect to eat and you like it, but you know I shouldn't like it, I shouldn't eat it because I will be more and more obese. So please be aware that everyone who tries or wants to feel healthy, the weight is very much important to keep in some measurements to height of the body. So please recommend your patient to keep eye on the weight. Also, they shouldn't drink alcohol during the evenings and nights. And of course, you should recommend regular sleep. Body position therapy, I have mentioned. Optimalized weight, I have mentioned. And if nothing like that works, then you should recommend the patient the conservative therapy. And if this doesn't work, then you have to ask ear, throat, nose doctors or specialists from the maxillofacial surgery, the stomatologist with the abilities of operations to help. And of course, the combination of all above. This is the same patient we just previously saw, and you see he's at the side of his body, and there is no problem with his breathing because the graph is regular. I will show you a little bit. Now he breathes normally. Let's move. So I've mentioned CPAP and BPAP is continual positive airway pressure and also bilevel positive airway pressure. It was found by Colin Sullivan in 1981. So you can see it is not very old treatment. It is quite young in comparison with other different type of treatments. And yeah, it is very much effective, and we love to use it. Here in Czech Republic, we can recommend this type of therapy when apnoea-hypopnea index reaches 15 or more per hour, episodes per hour, and it means that the patient has some mask on the face. Either it is nasal, just for the nose, or also for the nose and for the mouth. We call it full face. So you see special thing on the head of the patient, and here you see the line of the products, and you see that in time it gets tinier and nicer, and to look at, and it's a device which produces the air flow under pressure. And how big pressure, you can ask. This system are automatic, or you can use this as automatic in titration, or you can use also manual method, but maybe to leave the patient and to explain how it works and give the patient to try to their homes for a while. Then they can touch it, they can use it whenever they want. They just need to know or need to get used to it and trust it. And when they start to like it, they do not want to leave it anymore, because they just try to feel, or they just feel we are very well slept. We slept very well during the night. We are losing our excessive daytime sleepiness, and we just want to use it. Not every time it is so successful, but if it is very effective, and the apnoea-hypopnea index is just lowering up to 0 or up to normal. But if the patient doesn't tolerate it, then we need to discuss the case with our other colleagues, but with not such a good result as granted. It is really unsure how it will be later on after other type of therapy. The CPAP and BiPAP, what is it, the difference? Continuous positive air pressure, they have the range from 4 to 20 centimeters of the water in the strength of the power of the flow. BiPAP, they can do 5 centimeters more, and also that bi-level system, the inspiration expiration pressure can be up to 8 centimeters of the water, while the CPAPs with the function of C-flex, it's only 3, but 3 is quite okay, because it's like normal breathing in inspiration expiration. How it works in Czech Republic, the insurance company is covering this. And of course, then the patients are controlled, and we are supposed to enforce them to use it at least 50% of their sleep. And if they don't, they should put it back or give it back to the insurance company. But they like to use it in majority, and there's no problem to have a patient who uses it every day, 8 hours per night, 365 days per year. So we have such patients, and their apnoea-hypopnea index from 60, 70, 80 or so could be 0 or 1, so they are very much happy with it. Just one case, how we do it. This is his ear, throat, nose evaluation, then some medical history. Its apnoea-hypopnea index is 63.5. Here it says for sleepiness scale is 14 points. This is sleepy calendar. You see his episodes during the day. Then this is the polygraphy finding. This is 63 apnoea-hypopnea index. This is the biflex bi-level titration, and you see that in average device IPAP, it means inspiration pressure is 14 centimeters of water. And over 11 with expiration pressure, and the residual index apnoea-hypopnea is 1. So it's very, very effective. He used it 3 days, every day, over almost 9 hours. So he was very satisfied. After 1 year, this patient has compliance of 90%. Compliance means the usage to the cooperation with the device, the 90% of time of using it. The effort scale of sleepiness from 14 was reduced to 6 points. The pressure is around 14-15. Apnea-hypopnea index is from 63 to 1. Mask, he used nasal one only for the nose. Subjectively, he improved. Objectively, is recovered. A recommendation is just to use it every day and come again, please, in 1 year, because insurance company again cooperates with the supply of the little things they need with this device. The device is nowadays here covered by for 7 years, and those masks and tubes and filters from the device, it is 1 year, it's yearly replaced with the partly covered of the cover of the insurance company. Patient pays less, but they are usually they usually need to have the new things after 1 year. Surgical, I'm not surgeon, so I wouldn't be very much probably, I shouldn't be very much probably talking about this, but it's about tonsillectomy or some septoplasty or some tongue corrections, the size and the volume, but not sure if the result will be successful. So patients who do not tolerate CPAPs or BiPAPs. They are supposed to have these consultations, but with not sure result. If you want to know how we also work with the patients with besides our normal daytime practice, we also are supposed to do some researches, and this is my and my colleagues' result from cooperation with also my very best colleague and my example for my work, Professor Shonka from Prague, from Charles Clinic of Neurology of Charles University. Then here we measured OSA and its connection to stroke and cognition, and we found out that even the patients are having very high percentage of having OSA while they have a stroke. During 1 year, a little bit or significantly they improved without CPAPs, BiPAPs. But of course, these patients, you have to know that they should be in good conditions when you introduce the patient to treatment for these devices, because these patients after stroke could be disabled, could be hemiplegic, hemiparetic, and then if they have quite great motor disability, to titrate the patient is much more difficult. So I would point here, please, in your everyday daytime practice, check the patients whether they breathe normally when they sleep, and if they have some risk factors I've been speaking about, then please ask them to measure something, to ask the family members to check them. Even you can ask just to make some videos on your mobile phones, please, so we know what the patient is doing during the night. And then if it's witnessed the apneas and the patient snore, then it should be checked also in the sleep laboratories. And of course, be very aware of the sleep hygiene and your skills for eating and drinking and so on. Now let's move to central disorders with hypersomnolence. I would like to point narcolepsy, either with or without cataplexy. If it's with cataplexy, which means atonia of your muscles when awake, then it is type 1, and narcolepsy without cataplexy is type 2. What is it? It is sleep architecture disorder. The patient has daytime problems with imperative sleeps. It's sort of like a seizure of the sleep. Immediately the patient fall into sleep without wanting. They can have sleep paralysis. It means they wake up in REM phase, and in REM phase we have generalized atonia. And if you wake up in your REM sleep, then you feel you are paralyzed. How it works at the end, if somebody touches you and you are totally wake up, then it disappears. But it's very unpleasant feeling
Hi, I think she's having a connection problem, so we're just gonna try and solve it. If you can just wait a few minutes.
Can you hear me?
Yes, we can hear you now.
Yes, can you hear me? Yes, I'm sorry because somebody said to it that the meeting is being recorded and this was the problem. So I will continue quickly then. Excuse me. So we are here. Can you hear me okay? The cataplectic problem is the daytime problem of the patient with narcolepsy. Sorry, I would add money. The cataplexy is either localized or generalized atonia of the muscle when the patient with the narcolepsy is awake. So it's very, very also dangerous for them because you can imagine somebody who is laughing because it's usually connected to some mood, like sort of laugh or some maybe also the negative mood, but more likely with some happiness. And the patient, while is happy and laughing, they can fall on the floor, and it's very, very unpleasant feeling for them. I have a patient who was swimming in the sea or in the lake, and suddenly she felt she was like diving in because she had no muscle tone. So it's also very dangerous to just not to die from it if you are in a situation which is totally unpleasant to be in. Of course, this is because it looks like the sudden occurrence of sleep episodes during the day. You are not allowed to drive a car if you are not stabilized and you don't control your disease. How we diagnose this disease? We provide polysomnography. You've seen the little boy with those wires. So this is this measurement, this record, or and we use multiple sleep latency tests. And what does it mean? We have the patient in a sleep lab with the virus on the face and on the brain, because we need to know the REM or non-REM sleep or wakefulness. And also we need to know the muscle tone of the musculi mentalis, so it is on the patient's face. And we know that in REM sleep, we have muscle atonia. So if we see in this sleep latency tests, which are 5 times during the day, 30 minutes, and we measure each 2 hours, so 5 times during the days, each 2 hours, 30 minutes. And if the patient sleeps and falls into sleep, we are of course concerned how quickly the patient can sleep and if the REM sleep is there or not. Normal REM sleep comes in first time in 90 minutes of sleep. And if you see that these tests are in length 30 minutes and the REM sleep is there, it is abnormal. To diagnose narcolepsy, you need either one SOREM in PSG and one in MSLT, or 2 SOREMs in MSLT to support this diagnosis. And of course, the sleep latency shouldn't be longer than 8 or up to 10 minutes, as 10 minutes is cutoff value for the excessive daytime sleepiness. So who is over 10 minutes, then it should be meant as like more likely normal value. Also, we can support this diagnosis with the blood measurement, which is HLA system. Haplotype is a DQBI, HLA DQBI 0602. It is mentioned like this. It's the name of it. You can ask in laboratories to measure it for you, to find it. The patient is either positive or negative. There's nothing else the result. And if the result is positive, you have another supportive value to support this diagnosis. But if somebody has this sign and no clinical troubles, you are not allowed to give them the diagnosis. You just wait whether the illness comes or not. But usually we don't ask for this sign without any clinical sign. So it's no point to remember to make it to other patients who are not providing any sleep disorder. Of course, you need MRI scan because you want to exclude, let's say, tumor. And we also would like to know the level of hypocretin orexin, so you do lumbar puncture. And supportive measure is when there is almost no level of it in the cerebrospinal fluid, so it's less than 3 picograms per milliliter. I will show you just the one case. It's a man of 1967, was born in this year. You see totally disabled hypocretin, so you see low stages, but so many wakes up, and also the REM sleep is at the beginning, but I would say in this case is rather normal. But here we have the MSLT, it's a 5 times measured, so it's just the system puts it together, and you see it's a 1, 2, 3, 4, 5. So REM sleep is it's very pathological, and you see that the sleep latency in 5 values is 7 minutes. So it is pathological. He is HLA DQB10602 positive, and his hypocretin orexin level is lower than 30 picograms per milliliter. So this patient is truly narcoleptic, and the bad story is about that the first episode of falling into sleep was behind the wheel as truck driver, and he killed another one truck driver who was repairing the wheel by the side of the road. So you can have these very, very sad consequences of the illnesses as well. But previously he wasn't diagnosed for this type of illness, so it would nothing more that we can do that help him to live with this history. But he is not probably the one who causes himself by any other etiology, who just couldn't do anything better, I would say, about this case. I'm sorry for him. Then we have circadian rhythm sleep wake disorders, if I can move. Of course, there are much more illnesses in each section, but I would probably just point the main typical ones. So what is it, circadian rhythm disorder? It is about difficulty to fall into sleep, to wake up during sleep and wake up too early, and not being unable to fall into sleep again. Sorry for misstreams, I'm sorry. We can have advanced sleep phase, so we are not going to sleep at about 10 in the evening, but let's 6 or 5 in the early evening. Or we have delayed sleep phase. It means we like to fall into sleep after midnight or even later. Of course, we can feel the sleep disorders with circadian rhythm when we go to the other side of the world. So you have a situation with this called jet lag. It means that your internal clock is in different wave than the society you went to have a look. So you are supposed to synchronize your body with the other time zone as soon as possible. Of course, shift workers can have the problem, and irregular sleep is typical for dementive people, which are, let's say, having Alzheimer's disease, and then they just break their circadian rhythm system. So they sleep during the day, they wake up during the night, and it's quite difficult to take care of these people at home because you need to sleep while they are awake. And of course, we have some because we are controlled by the light and by the darkness. Blind people can have non-24-hour syndrome. It means that they have the system longer. What we can do, we can of course force the people to be on light and to sleep during the dark. which I would like to say that if there is anyone who would like to have other time zone, like in Europe, we have 1 hour in the summer, in the spring, and 1 hour in the autumn, like winter time and summertime. It matters which part of Europe we are, because the people from the north and people from the Central Europe, we really are happy with the winter time because we have more light during the day later on. Sleep hygiene is very important. Lifestyle is very important. Medication you can support with melatonin or chronotherapy. It means timing of falling into sleep should be very well considered. Sleep-related movement disorders. Here we have periodic limb movements. It means it is neurosensomotor disorder of unknown origin. The people, what they do, they rhythmically move mostly or in their lower extremities. It is linked to sleep. Duration of movements is about half or up to 5 seconds, and it's periodic from 5 to 90 per hour. So you can see it could be also very annoying because while the patient moves the legs, they have arousals, so it is disruptive for the sleep. The sleep fragmentation results from this condition. And of course, the patient can have some motion-related awakening reactions, and the quality of sleep is poor. It is more common in older men. It is associated somehow with Parkinson's disease, with obstructive sleep apnea, with people with illnesses of the kidneys, illnesses of the muscles, and could be also related to diabetes mellitus and also to coughing during the night. And of course, you should check iron metabolism to supply if it's less than the normal level. I would like to show you how it looks like. Hopefully it's not that long to show you. So the patient is on the side sleeping, and you see some muscle activity here. It's a right leg, left leg, and you here see, and this is it. And they do it like this. They do it periodically during the night, and you see a little arousal reaction of the brain. And here also you can see the disruptive hypnogram, if you remember how it should look like normal. Therapy, we administer to patient L-DOPA agonists or L-DOPA, gabapentin and benzodiazepines, clonazepam, and casual, of course, if known. I meant that I have mentioned that iron deficiency, so you can supply the patient with this. Parasomnias. Parasomnias are very important for neurologists because we can switch. Either it is parasomnia or it is sleep-related epileptic trouble, epileptic seizures, and they can look pretty similar. So we really have to be very much aware not to give the patient wrong diagnosis. If they are connected, related to non-REM sleep, we talk about sleepwalking, what is called somnambulism, or we can speak about night terrors or confusional arousal. And if it's connected to REM sleep, it is nightmare. And of course, very important is REM-related behavior disorder. It means abnormal behavior during REM sleep, and it is high risk factor for possibly neurodegenerative illness, morbus Parkinson in a time. It could be previously as a sign, clinical sign, 8 years almost when the Parkinson disease appears. So it could be very much important to know about this. But even we know that it is somehow connected, we cannot stop to involve or evolve the brain of the patient into the Parkinsonism. And epilepsy, it is very much important, let's say, for me, especially frontal lobe epilepsy, because it is more likely connected to night sleep or to the sleep. We use polysomnography, PSG, and video EEG. I would like to show you a patient.
ty, stój tu. Momentálně totálně stojíš.
This is his video EEG, and this is PSG. You see he snores, but it is not about the sleep apnea in this case, but just snoring.
Co to je tu zážitek?
So you see that the patient is waking up. The situation is quite similar. His behavior is similar. He talks in a local dialect, so it could be meant as funny for our people who doesn't understand what he says. But in this area, or Salesian area, the people usually speak this language, so it's not that much pathology. But you see, this is this situation that he was in deep sleep, and suddenly he woke up and he was confused. So after all, we gave him diagnosis of confusion arousal as parasomnia and not epilepsy, because previously the other colleagues thought that that was epilepsy, and he was treated as epileptic. So we just changed the diagnosis into this, and he was later on a bit better on clonazepam. You have here now, you could see this one. Let me stop here. You see the EEG, it looks like wakefulness, but here you see the movement of the eyes. So this is REM sleep, and this patient is laughing, she is moving, she is having some sort of vivid dreams, and she doesn't remember, so I will show a little bit more. The other one. They say from home that she is quiet while during the nights, that she's screaming, laughing, and so this is REM-related behavior disorder. So in this case, she's not Parkinsonic so far, but we don't know, and we should be following her whether it comes or not. And if the Parkinsonism appears, then of course she needs a special treatment and medication, but not previously. We just have to wait. And what about this one? You see the patient with the night, he was waking up, and then he had some tonic episode, and then he sits up and has a look at the watch, how much time it was, and we can see here is the EEG, and here is a polysomnography, and the semiology of these behavioral troubles is very similar. And although we didn't see the spikes and waves or some epileptic focus on these recordings, this patient was evaluated for having the epilepsy, and he was also at the epilepsy surgery, and he still has some seizures during the nights, but they are depending on how much work he has, and he usually works from the morning to the evening all the time. So he says, when I don't work and have a holiday, I'm much better. So it's hard to help him more probably. What about this one? This is a woman, 27 years old, and this woman had so many episodes, about 50 per night, when she was sleeping, opening her eyes, closing eyes, and you see this pattern. This is generalized epileptiform discharges. These are the pattern. So the girl was after all diagnosed of having generalized epilepsy of Jeevan's type, which is probably beyond this session. So it is about epilepsy, but she just opens the eyes, closes the eyes. So disruptive sleep, but it is epilepsy. What about this one? You can see also when she sleeps, the tachycardia. We call it pre-ictal tachycardia. This is a patient who has the sleep-related epilepsy as well, and she's very depressive, and it's very hard to work with her. But I would like to also send her to our colleagues to epilepsy surgery, but she denies it. She doesn't want so far. And what else we have? We have to be aware that some medicaments also can provoke the sleep disorder, drowsiness or insomnia. So please, when you administer any recommend any medicine to your patient, please be aware of side effects. Check it if you are not sure, not to make patient even more sleepy or even more insomniac than they already are. It means some beta blockers, they can provoke cough, so they will not be sleepy. Also, corticosteroids can do it, anorectics, nasal decongestives, and amphetamines. And anticonvulsant, neuroleptic, antidepressant, hypnotic, antiemetic, anodynes, antihistamines, they all can make the patient sleepy. In case of epilepsy, we use slow titration, up titration of anticonvulsants, so the patient has less side effects than they should have or they would have if we are in a hurry. I would like now to give you some cases to think about. We have male, 55 years old, with BMI 33, so it's obese. He has increased daytime sleepiness, and we don't know if he has apneic episodes. In medical history, he has myocardial infarction, and he's after bypass graft, so it's after the therapy of the myocard with the special procedure. He has hypertension on 4 medicament combination therapy. He has diabetes mellitus and is on diet and on the medication for it. He snores, and what we would like to think of a disease. In this case, it is about sleep apnea, obstructive sleep apnea. We have a student, second case, 24 years old with BMI 24. It's a daily imperative sleep, difficulty about 4 years. He sleeps poorly at night, and he knows sleep paralysis, so he wakes up and he couldn't move. Then his head drops when he laughs. He has no learning difficulties. He has driving license. So what we are trying to think about, it is about narcolepsy. And because he laughs and he has head drops, so we think it is about narcolepsy type 1. It means with cataplexy. Case 3 is a female, 45 years old, divorced, 3 months out of work. She is in climacteric episode, so over, let's say, 50 years of age. She's sweating a lot during the night. She's difficulty falling into sleep, and she stays asleep and staying asleep. She doesn't snore. She has difficulty over 3 months. She tried teas. She doesn't drink coffee. She doesn't do any sports. She goes to bed around 10 p.m. and she goes to the toilet during the sleep about 3 times. What it should be? It is probably about insomnia related to the phase of the life. So we also need to consult a gynecologist and maybe some support her with some hormonal therapy if it's allowed, if it's possible. And we have female, she hasn't slept for about 10 years and her conditions just appeared after glandular penialis surgery 10 years ago. She couldn't sleep so well since then, and she has depressive dreams. What etiology of insomnia this could be? It is about the lack of melatonin, because we are talking about glandular penialis, and glandular penialis produces that melatonin. So we causally we gave her melatonin and she improved. So it was very fine for her. And we have a female, 34 years old, BMI is 22, and she has numerous psychomotor restlessness during sleep, morning amnesia to conditions. Conditions are very similar nature. She had childhood epilepsy and she's on no medication. What we should do the video EEG or maybe polysomnography, because she's suspicious of having the relapse of epilepsy with sleep-related seizures. So to summarize, please, when you are once in your practices, please, beside the history of arterial hypertension, about diabetes, about some operations, please ask the patients how they sleep. If they say, I have no problem, then also you might ask, and do you snore? And he said, oh yes, I snore and I have no problem because my wife just kicked me off maybe 10 years ago to other rooms, so I'm a very good sleeper. But in that case, we don't know about the apneas or at all, so we have to check it. We need also the objective history. It means if the patient doesn't know, please ask somebody from the family or from and abnormal sleep, and of course you are supposed to know about the possibly seizure illness, about the epilepsy, because it can mimic the problem of the sleep. So to conclude, sleep disorders are very common. However, they are mostly undiagnosed or inadequately treated. In our common practice, it is sufficient to ask a few questions for the capturing it, and the answer I don't know is not sufficient. You are supposed to try to look at it more properly, just in case that you are still suspicious that the patient has a sleep trouble. If you are satisfied with your sleep, it's okay with us. If the patient is satisfied, it's okay. So why we should be more concerned. But if the patient is feel more sleeping during the day without obvious causes, we are of course quite concerned. If something occurs unusually during the sleep, please ask the others what they see. And the snoring phenomenon and the daytime sleepiness, it is very much high risk for having sleep apnea, which is very much important to know. And here I just put 4 different pictures. This is me, my own picture from the skiing holiday. So it doesn't matter which condition we are, where we are, or what are the consequences. We should be concerned either if it's good mood, or if it's about the balance of the life of the patient, or if they have to say, if they have to solve many troubles during the day or during the night and work very hard, or if they are on the road and they should pay attention on the forest of these signs, and they say, sorry, I cannot follow the signs because there are too many, because it could be also true. So please ask the patients properly about their medical history, objective medical history, and maybe then you will be very much helpful to your patients in your lives. So thank you very much for your attention, and I am ready to discuss or to answer the questions, but I just don't know if I somehow will be possibly in connection with you. So either you can chat with me, or I don't know if I can hear you, because we were trying with Ceza to do it, but I couldn't hear her. So if you want to ask whatever, you are very much welcome. Hope I could speak what I call English in my case, so you probably could understand me. I'm very much sorry for any misprints or some bad pronunciation, but I hope you understood and you just took what you wanted from this talk. So ask me if I can ask Ceza to help, or how it could be. I just asked, can you hear me? Can you hear me? And I say, any questions? Maybe you should unmute your mobile phones if you want to ask something. Okay, then I check with Ceza via phone what I should do. I see. Okay. So if no questions, thank you very much for your attention, and welcome in our clinic, if interested in sleep or epilepsy topic, or any other topic we can offer to show you.
Thank you very much. It's a very good lecture.
No questions. Thank you, Professor.
Hold on. If anybody wants to fill out a feedback form, you will get a certificate to show that you have attended this lecture. So let me know if you can see the screen. You just need to scan that code and you'll get a feedback form, and after that, a certificate will be generated for you.
Thank you. Can I get also the certificate? Can I have one too?
Yes, we can make you a specific certificate and we will send you the feedback.
I could have one too. Okay, thank you very much. It was my pleasure. It was my pleasure, and if everyone now can hear me, so thank you very much for your attention. Thank you very much. You spent the time with me. I hope it was helpful for you. And if I can point at the end something or some book you should read, it is the book which is named Why We Sleep. And it is written by scientists of sleep, which is very much, I would say, likable and understandable. His name is Matthew Walker. And if you are interested, so you can check also many talks with him in the internet. And Why We Sleep is the basic book to understand the basic circles of the life, and you will understand. And if you will understand, if you sleep well, you will be healthier and you will be better doctors, which of course is very difficult when you start to work with night shifts. Then it's really annoying, but in a time you should be very much concerned about the sleep.
Thank you.
So thank you very much.
Thank you for the recommendation, Professor.
I'm switching off. Thank you very much. Thank you.
Bye.
Thank you.
You too. Bye-bye. Bye-bye.
I'll leave this form on for about a minute and then I will end the meeting.